we talk about genetic testing now, and there's a lot of different types of genetic testing, but the kind that you're talking about is germline genetic testing. It's genetic testing that happens in the blood, and it's the DNA. You're looking for mutations in the DNA that are present in every cell in your body. It's the stuff that you inherit from your parents, and that is what I think you're talking about, right? That is about whether or not you're at risk at baseline, a higher risk of getting melanoma. And we want, we try to you don't want to do genetic testing on absolutely everyone, because the cost is still prohibitive to be doing it on everyone. So you want a certain level of risk, which is probably around 10% chance ahead of time. We call it pre-test probability. You want about a 10% pre-test probability that somebody has a chance of having a mutation. And we base that on features about the person themselves, how many melanomas they've had themselves. If they've had 3 or more melanomas themselves, then that's a sign that they have probably something going on. If there's melanomas in multiple family members, then that's a sign that it's being inherited, that there's something that's being inherited through the generations. And that so we also count 3 when we have 3 melanomas in a person in a first or second degree relative, then that counts as someone who is at high enough risk to warrant testing. And then we also think about other cancers because melanoma sometimes occurs in the context of other cancers that suggest the melanoma gene. So, for example, one of the most common hereditary melanomas is caused by CDKN2A, or cyclin-dependent kinase inhibitor 2A, which is also commonly referred to as P16. And that gene, for example, is also associated with the risk, a fairly high risk for pancreatic cancer, especially in some families. And so what you want to do is, if you have a person who has couple of melanomas, but they also have a mother, for example, that has pancreatic cancer, then even that's not 3, that's 2 plus pancreatic cancer, that gives you a tip-off that that's also heredity. So anytime, and we're getting to the point where testing now, you can test a large number of genes at one time. And so it makes a lot of sense to be thinking about all the different cancers in the family that may be inherited, because it's not as black and white as when you get one mutation in one gene, then you're only at risk for that cancer. Does that make sense? So when you're looking at how do you identify them? I think that was your question, really. How do you identify these guys? You identify it by an excess amount of cancer in themselves and their blood relatives. And it doesn't always have to be just melanoma. Melanoma happens after you get additional mutations in one of your melanocytes. It's either in the normal skin or in moles, right? There's a huge collection of nevomelanocytes in the moles. And so when those get another hit, usually from ultraviolet radiation, they get a hit, and they'll develop slowly but surely. They can sort of progress into a state where they finally have cancer, where it's now a full-blown melanoma. And at that point, then if you cut it out, the first treatment is surgery. If you get it before it spread, yay, you're done. You've got a scar, but you don't have, your life is saved, right? Because you've gotten rid of the cancer altogether. But like I said, it's 1 millimeter or so. It's about the time when things start to spread. So you've got to get it early. But if you don't get it early, then the next treatment part is to determine how far it spreads. So you get staged with things like a lymph node biopsy, and you get staged with radiological testing, imaging, to be able to see if they see anything anywhere else. They also then test the melanoma itself, right? They take a piece of the melanoma and they do genetic testing on that. And if there are certain mutations in there, like, so one of the mutations is a BRAF mutation or an NRAS mutation or a c-KIT mutation, those genes, there are certain drugs that can specifically target those pathways that have gone bad because of the mutation. And when they, so BRAF inhibitors, NRAS inhibitors, for c-KIT, imatinib, it's another drug that that's able to hit the c-KIT receptor sometimes. So those are the ones that that people have available to them. But then, in addition to that, not everyone has a mutation that's targetable by one of those drugs, and we have immunotherapy in melanoma, which is really wonderful because immunotherapy doesn't discriminate, based on the mutation that you've got. Everybody's immune system has the potential to respond. So, for example, with CDKN2A, you've got pancreatic cancer, and also astrocytoma is another one, and potentially ocular. There's some hints of ocular melanoma. And so you think about it and you're like, well, what's the good of the knowledge? The benefit is that you can then be screened for all those potential cancers on a regular basis before you end up getting that cancer, right? So if you're, you can't, I mentioned you cannot see the inside of your body, right? Pancreas is deep inside. You're not going to be able to see it on the outside, but if you're aware, you can have things like a glucose. You can have a serum glucose to see on a regular basis whether or not you're developing diabetes. You can have on an annual basis, you might want to have there's two sort of different tests, imaging tests, that are considered really good for pancreatic cancer. One is a MRCP, which is an MRI-based evaluation of that area of the body. And then another is an endoscopic ultrasound, which means you have to go down in with an endoscope and look with an ultrasound down there so that you can get in deep enough. And so oftentimes you'll alternate between the two of those. One year you'll do the MRCP, the next year you'll do the endoscopic ultrasound, you'll do the serum glucose every year. And obviously you're also paying attention to signs, right? So you can have an ophthalmologic exam once a year just to make sure there's nothing on the back of your eye that is coming up. And if there is, you can be examined by and followed very carefully by an ophthalmologic surgeon. And even when you're being checked by everyone, all of those providers that you have that you're going to be checked by on a regular basis, they ask you about signs like neurological signs, so that if there's anything that is even a hint that something is coming up, then you can have another imaging study to make sure that that's not happening to you. And so what it is it's all about screening, right? And so there's another gene called BAP1, and BAP1 has a different spectrum of cancers that is associated with it. So it's associated with basal cell carcinoma of the skin as well, but it's also associated with very strong association with ocular melanoma and an association with mesothelioma, which is a very specialized form of cancer on the pleura of the lung. And then it's also at higher risk for renal cell carcinoma. So in that case, you're not doing a pancreatic cancer screening, you're doing more of a renal ultrasound, and you're doing an MRI to look at the mesothelioma. So anyway, there's ways that you can tailor the screening that you get based on the mutation that is found. And that, again, is back in the germline type of mutation, not the somatic mutation that's present in the melanomas themselves when they form.